Okay, I think we might get started now. First of all, I'd like to welcome everyone and thank you for joining the last of our FASD Hub webinars for 2021. Now, many of you will know that the Australian NHMRC guidelines, which were recently updated in 2020, recommend that women who are planning a pregnancy or who are pregnant or who are breastfeeding do not drink alcohol. And yet alcohol in pregnancy remains very common. And we know from current pregnancy cohorts that between 60 and 70% of women say they drink alcohol during pregnancy, although this is often in the early phases of pregnancy before they realise that they're pregnant. Well, so what? Does this matter? Well, we know that prenatal alcohol exposure can cause a whole variety of poor pregnancy outcomes: miscarriage, low birth weight, prematurity and stillbirth. But we know that prenatal alcohol exposure can also harm the unborn baby in many ways, and that this increases the risk of a whole range of outcomes such as birth defects, cerebral palsy, and poor educational outcomes. Alcohol in pregnancy may also result in fetal alcohol spectrum disorder, and it's associated, as you know, with many lifelong harms. And even in adulthood, we know that people with fetal alcohol spectrum disorder are more likely to have problems with mental health, substance use, and difficulties with independent living. So many clinicians tell us that they don't know about alcohol harms in pregnancy. They don't know how to ask about alcohol use in pregnancy. They don't know what to advise. They don't know where to refer women. And they're worried about stigmatising women and families and about disrupting the patient clinician relationship. Conversely, many women tell us that they want to be asked about alcohol use in pregnancy. They want to be advised. They're not worried about the issue of stigmatisation. They want to be informed so that they can make informed decisions. However, many women also tell us that they don't understand what are the potential harms of alcohol use in pregnancy. So today I'd like to introduce the case of a woman who is drinking alcohol in pregnancy, and I'll seek your perspectives in the audience and the perspectives of our panellists. So that next brings me to a welcome to our panellists, and I'll introduce each of you later before I ask you some questions. And just remiss of me, I forgot to acknowledge the traditional owners of the land on which we meet, and I'm on Gadigal land of the Eora Nation. And I pay my respects to the traditional owners past, present and future. So I'm now just going to give you a little case, and this is not an atypical case. One of the problems we have with health clinicians is they have very fixed ideas about who might or might not drink during pregnancy. So I'm just going to tell you about this case. Obviously the names have changed. This is the sort of patient that we might see in our clinic. So Susan is a 24-year-old woman who you might see in your practice or service or organisation. She's just found out that she's pregnant and she's about 3 months. Now on TV, she saw one of the government's new advertisements warning about the potential harms of alcohol for the unborn child. And the message in that advertisement is that every moment matters in pregnancy, and that the moment you plan to get pregnant should be the moment that you give up alcohol. But Susan hadn't realised that alcohol in pregnancy was harmful. She rapidly went to the FASD Hub and looked up more information, and she comes to you now because she's worried that there may be some damage to her baby. Now, you learn from Susan that she's a single woman, she's got a university degree, and she's been working as an accountant for a hotel group, but she's currently unemployed because the business closed down during COVID. She also tells you that she's recently escaped from a violent relationship, and it was only then that she found out she was pregnant, and she lives alone. So to deal with all these stresses of COVID, the separation, the domestic violence, she tells you that 6 months ago, that's 3 months before the pregnancy, she started drinking more frequently and in larger amounts. And she now drinks about 5 glasses of wine every evening. And those glasses are sometimes big glasses. So you calculate that she's probably got quite a high level of alcohol intake. So now I want to turn to our panelists. And the first of our panelists is Angelene Bruce. Welcome, Angelene. Angelene's a biological mother of a 12-year-old child who's got fetal alcohol spectrum disorder. And she's a great advocate for families living with FASD with a clear aim to end the stigma surrounding FASD and to bring it out of the shadows, to start conversations, to shine a light on what she calls this invisible disability. Now, she's a great mentor for caregivers, and she's particularly passionate about supporting other biological women who have been unable to stop during pregnancy and who are now finding that they're caring for a child with fetal alcohol spectrum disorder. She really wants to assist them to understand the harms of alcohol use in pregnancy, to obtain an early diagnosis and to obtain early intervention for their child. So, Angelene, perhaps you could just start by telling us a little bit about the experience that you had in pregnancy in relation to your alcohol use.
Thanks, Lisa. And good morning to everybody. Thank you so much for being here. My experience was that I was a 34-year-old woman. I had been told by top specialists that I had absolutely zero chance of falling pregnant without IVF intervention, which I could not afford. My mother passed away very suddenly from a glioblastoma. I think we all know that there's no good outcomes from that brain cancer. There still hasn't been. I was self-medicating on that. I did have early childhood trauma. I dealt with that in non-alcoholic ways. However, then I found out I couldn't have children and I was self-medicating on that. So by the end of all this, I was a 24/7 top-up drunk. And yeah, I was very, very, very physically dependent on alcohol. And then I found out I was pregnant with, I see the irony in all of this, with my miracle child. So I took myself off to my OBGYN appointment and I disclosed that I was an alcoholic and that I was in full flight. And the response that I got was very short, sharp. I will never forget it. It was, you know that alcohol is bad for the baby. You must stop that right now. That's it. That's what I got. I was very, very well aware that alcohol was not good. So then it was over to Mr. Google for the rest of the time. It takes a lot of courage for people to come out and say that they've been drinking alcohol, specifically in larger amounts, for fear of shame, stigmatization, et cetera, et cetera. So from then on, I have Rh negative blood, so I had to have anti-D shots. So I went to all of my appointments. I took prenatal vitamins. I cut down drinking as much as I could. But the second that I would go into physical withdrawal, my son would get in trouble and I would start to lose him and end up in hospital. So it was it was a knife edge. I had to go through it alone. I was not forthcoming after my first point of contact. And I think the very first point of contact with a primary healthcare provider is super important. It's a window where someone's saying, you know, help. What I wished, I like Susan's case study very much. What I would like to have happened was, putting it frankly, I think my OBGYN neglected to remember that I was actually his patient, not my son at that point. I was only 8 weeks pregnant. So I left feeling like a failed vessel that was not protecting this precious little being inside of her. And I already knew that information. What I would like to have seen was a clear acceptance that nobody becomes an alcoholic for no reason. There is trauma there, be it childhood, there's going to be trauma. What I would have liked and what I would like to suggest to any clinicians out there is that first up, we need to deal with Susan, or we would have dealt with me. I'll put it in Susan's way, in the way I wish it had have gone, if that's okay. So the very first thing I would say is, as much as you're training, and believe me, we're all human, as much as you're human and your training wants you to go straight to bub, please remember that myself and Susan are your patients. Because in situations like this, Susan may miscarry and she's still going to need to be your patient after that with, non-judgment consolation, consoling, stuff like that. The next thing I would do in order for treating Susan and myself, if I could go back, was immediately initiate a Medicare mental health care plan. That's what they're there for. The initial 6 with the 5 there with a Medicare subsidisation, because there's clearly trauma, and unless we can address Susan's issue and mine at the time, then it's going to be a very, very uphill slope. It was a very lonely journey for me. All I could find, it was 2008, my son was born in 2009, all I could find was stuff on Google about sentinel features. And because every moment matters, it's probably pertinent to say that those facial features only occur between days 19 and 22 of gestation. So they are far from a true indicator of FASD, but that's the only info I could really find at the time, these sentinel facial features. So
Angelene, what about before you got pregnant? Do you think there was a missed opportunity there if you'd been drinking for a while? Had you got a regular GP or anyone that you saw?
Yes. I had actually been through Odyssey House here in Victoria for 5 months. So that was a double-edged sword, because I had known from that experience how physically hard withdrawal was. And I also knew that I needed to be loaded up with an inordinate amount of Valium for at least 5 days to do that. In my particular instance, it was a risk that I wasn't willing to take in my first trimester. And so as far as what could I have done prior, I was already in relapse on the information that I was never going to have a baby. So that, yeah.
So you've given us some really good advice as professionals. What advice would you give Susan if you came across her now? Because you do a lot of support of young mums, don't you?
I do. And my very first message to Susan would be, you are not alone. You love your child. No woman intends to hurt her child. Given that Susan's already drinking, she's at a high level. She will have some kind of physical dependence, so she will have some unpleasant side effects. And those unpleasant side effects, just like the alcohol, will affect Bub when it disappears. So I would also suggest straight up to Susan that there are heaps of support groups out there with a no blame, no shame approach, that there are other mums out there, such as myself, who have made a plan throughout pregnancy and for early intervention. So I like to call my son FASD strong, which means that he's been in speech and OT since 3, he's been in psych since 10, his school is very, very well versed. I may or may not be that parent, but I make no apology. So he's very well accommodated at school. And so he is FASD strong. He is not being kept in. He's not the naughty kid. He's been very well accommodated. So I would let Susan know that, even if your child is going to be born with fetal alcohol spectrum disorder, your life may look a little bit different, but with accommodations, that's just it. Life just looks a little bit different.
Yeah, look at that.
I'm driving to therapy 3 days a week instead of sport. So life looks different for us, but there is a lot of support out there. There are a lot of accommodations. We need to get creative as parents of FASD kids. It's a very unique, extreme parenting situation, but with the right accommodations and interventions, your kids can be FASD strong from very young. So I would firstly, Susan, you are absolutely not alone. There are other women out there. I'm on Twitter, and I'm happy for my Twitter to be published for everybody.
Perhaps you could put that in the chat, Angelina.
I leave my DMs open for that very reason.
Right.
So she's not alone. There are other women out there that have been through this. Please reach out to them. If she can give up alcohol, that's fabulous. If it turns out that she can't, we still can't go ahead with extreme judgment if she's trying to do harm minimisation, as I did myself. But at least she's not trying to muddle through by herself in the dark and crying on Google every night. So, yeah, please, if we're telling you, we want help and we need it and it's out there. And yeah, you can send any birth mums my way if you like. That's what I'm here for.
Angelene, thank you so much for your honesty and for sharing that story, because it's so helpful to us as clinicians to hear the reality of what happens, and to also hear that if children are identified at risk early, they can be plugged into early intervention programs, which really make a difference to their lives and to your expectations, I think, as a parent.
Can I make one more comment?
Yeah, sure.
Sorry. The final comment that I would like to have seen with my son, any child actually, with birth prenatal records. If there's alcohol consumed, I'd love for there to be a pre-marker. It's just a little box tick like smoking, or for me, Rh negative blood, etc. So that if the children start presenting with symptoms, which actually look like behaviours because it's invisible, it's brain damage, then we could go back to prenatal records and look for FASD first, as opposed to going through 6 or 7 different diagnoses before we get to FASD. So I'd really like to see a birth marker, put on just as a matter of fact prenatal record. As we've said, 70% of women drinking before pregnancy. It's it's more not a do you drink alcohol, just okay, so you smoke cigarettes? Yes, no. And how much alcohol do you drink? Because we're in Aussie land. So normalise it.
No, thank you for that. And of course, in our clinic, we spend a lot of time trying to chase up the alcohol exposure details. So we're all for advocating for good recording in the GP practice, in the perinatal setting, and of course in the obstetric practices. So thank you, Angelene. We'll now move on to Kateconograve, and Kate is an addiction medicine specialist and a public health physician who is based at the Royal Prince Alfred Hospital in Sydney and the University of Sydney. Her work combines treating individuals with alcohol, drug and tobacco problems with promoting health in communities, research and teaching. Kate has published very widely, and she's editor of the Oxford University Press Handbook on Addiction Medicine. She chaired, as I said earlier, the NHMRC committee, which revised the guidelines, the national guidelines, to reduce the health risks from drinking alcohol. And that does have a section on pregnancy. So Kate, welcome. Now, I can't see Kate, so I don't know whether everyone else can. Can you hear me, Kate? Great. Oh, there you are.
I can hear you. Yeah, I wasn't able to unmute there.
No, that's magic. So, Kate, you chaired the NHMRC committee, as I've said, and I noticed that the guidelines are stronger. They've got progressively stronger between 2002, 2009 and 2020, and they now advocate that alcohol should not be used in pregnancy or when planning for a pregnancy. What most influenced that decision to strengthen those recommendations?
We decided that real women needed clarity. Women wanted to know, and we needed absolute clarity. And we also thought that in pregnancy, one normally uses what we call the precautionary principle. If, for example, we knew a medicine was bad for you in high doses and caused brain damage, we wouldn't say, oh, but it's probably okay in low doses. We'd say that the human brain is incredibly precious, so don't use that medication. So we needed to apply the same standards to alcohol that we applied to food and medicines. And that's why we said no alcohol in pregnancy, because we don't know, there isn't a clear threshold that above this amount is risky, below that amount's not. And because there's not a clear threshold, having nothing is the safe way to go.
Yes, I mean, as you know, there's a deal of scepticism about the harms that prenatal alcohol exposure can cause, which persists amongst the medical community. And often they say there isn't the evidence in humans. But I mean, I totally agree with you on the precautionary approach. We do know also from animal data that even small amounts of alcohol can cause problems at a sort of subclinical level. So I think that approach is absolutely the right way to go. Now, Kate, just to change tack slightly, you work a lot in Aboriginal communities. Can you tell us what insights into the management of alcohol use in pregnancy and the prevention of harms that you've gained from that work?
I should acknowledge I'm sitting in the medical land of the Eora Nation. I think one of the things I'd like to say first up is very much like Angelina said, that people feel so much shame if they have been drinking and they fear that they could have hurt their child. And then it's on steroids, if you look at it in the Aboriginal community, because they've also got this huge fear of child removal because they've seen it all before. So coming in right from the beginning, exactly as Angelene said, to make it clear, you know, we're here to support you. We can make your life easier. That you've got stuck in this vicious cycle where you're using alcohol to manage your stress and your trauma. But in the background, the alcohol's probably making it worse. It's probably making your sleep worse. It's making your mood lower, and then your brain isn't, it's very hard for you to get clear to tackle with this. So we can help you, and we can help you stop the alcohol. We can manage that withdrawal so you don't have to be sick and your baby doesn't have to be sick. So, you know, exactly as Angelina said, we're there to walk with you and to get you in a better spot. And, you know, good on you for being upfront. And let's see what we can do right now to start making things better for you. And if you're ready to have a go at seeing if you can tackle the alcohol, everything you can do will, you know, will be a good thing for your bub.
Kate, you're a drug and alcohol specialist. Do you often see joint use of drugs and alcohol in your practice, and how do you deal with that? Because often we find that when we see children, people have sort of dismissed the alcohol and focused on the drug use during pregnancy.
Yes, well, of course, alcohol causes many, many more harms across the community than drugs do, but it often gets forgotten. And as I think Angelene said, it's very normalised, you know, drinking everywhere. And I've had young women who are trying to get pregnant say, it's, you know, I don't want to drink, but people are pushing me to have a drink. And I don't necessarily want to tell everyone that I'm trying to get pregnant. So I think as a society, we need to back off a little bit on alcohol and realise it's very double-edged sword with a lot of harms associated. So yes, I have clients, Aboriginal and non-Aboriginal, they drink alcohol or use drugs. And as Angelene said, many have a background of trauma, not all, but many. But for most, it's hard to get anywhere with coming to terms with trauma unless you can first come to terms, you know, get the alcohol and drugs a bit more under control.
Yes, I think that's a really good point. So what advice would you give, Susan?
I'd be saying, let's get you some help. Well, are you prepared to have a go? We can help you stop. And if you can stop, not only will it be better for your baby, but you'll feel better. You'll sleep better. Your mood will actually be a bit better and you'll be able to start moving forward. Are you prepared to have a go? And if so, let me link you. We'll manage your withdrawal and so that you can be comfortable and the baby can be safe. And then we'll link you with support afterwards to help you stay away from the grog afterwards, because that's the really hard bit.
Thanks, Kate. Now, Hester, can I introduce you? Esther Wilson is a GP and a fellow of the Royal Australasian College of GPs, and she chairs their special interest group in addiction. Heather is also a fellow of the chapter of addiction medicine in the Royal Australasian College of Physicians. She works as a GP in southeastern Sydney local health district and in their drug and alcohol service. And she's also in general practice in Newtown. And I think Hester does a lot of work with university students who, of course, are a very vulnerable population. So welcome, Hester. And if I could ask you a few questions, and just to remind everyone before I do enter any questions you have in the Q&A facility on your computer. So Hester, we've got a study of pregnancy cohort study in the Hunter, New England district at the moment, and we found that very few general paediatricians, general practitioners had actually asked any of those women about alcohol before they presented to the antenatal service at the hospital. What do you think is the role of the GP in preventing and managing alcohol use in pregnancy, because you're the one that are in there very early.
Yeah, absolutely. GPs see 86.7% of our community at least once a year. So we see young women. We see young women very commonly, and so we're absolutely in the right place to be asking those questions. The question to my mind is, why aren't we? Certainly the College of GPs has very clear guidelines about asking everybody yearly and opportunistically over the age of 15 about alcohol use as well as tobacco and other drugs. And even has a statement about asking younger people about their alcohol use. And we very commonly will see women, particularly when they're starting out on their reproductive and sexual life journey, for contraception, for women's health issues. So we're really in a really great place to do it. But it's interesting that we're not asking. I do think that there is some reluctance on the part of GPs of, so if I ask this, I don't know what I'm going to hear. Is it my role? And a really important one, is my patient going to be upset that I've asked them this? And what we clearly know from the patient research is, no, they expect us to ask. They expect us to ask about lifestyle issues. And look, I love the way that Angelene asked that question. So it's around, just assuming that this is normal, that people in Australia really commonly do drink alcohol, and we can just ask how much. Look, I understand some of the hesitancy around saying, look, there isn't the evidence, but to my mind, as a kind of a common sense GP, we tell women not to eat salami and soft cheeses, because of the risk of listeria. Is, to my mind, it's for the majority of women where it is easy for them to stop drinking for that period of time. Why not just do that and ask that? For people like Angelene, I mean, I think the thing for me that as a GP immediately I'm thinking is, Angelene is grief-stricken. She's just learned that she can't have children, and what we needed to do was to intervene and support her through her grief, so that she wasn't actually drinking very heavily when she then, fell pregnant with her miracle baby. But for Angelene, who had an alcohol use disorder, it's not enough just to say to her, just stop. And so for us as GPs, it is that screening, it's that flagging, finding, being open and non-judgmental, so that Angelene feels she can open up to us, or the person in the case study, and then knowing where to get support for that person, because they need lots of help to actually change their alcohol use. It's not in their control.
So Hester, you mentioned young women, and I've just been involved in a study with Delise Hutchinson where they followed young women for 20 years through their teenage years into young adulthood and into their first pregnancy. And they found there was a high consistency between the women who were drinking before and during their pregnancy, both in the first trimester and interestingly, again, in the third trimester. I mean, I feel that there are missed opportunities there in general practice for knowing our patients well enough to be able to sort of flag them. There used to be a thing called lifestyle scripts for GPs. I don't know if you remember those.
I do indeed.
I'm older than you, but what enablers are there in general practice, and how can we sort of better address this, do you think, to enable GPs to ask and advise and to overcome some of those barriers that you mentioned?
I do think that things like sort of education campaigns that actually put that information out there. Certainly one of the conversations that I've been having recently with my colleagues is this whole question of, but is a little bit of alcohol okay? Is a little bit of alcohol early in pregnancy okay? And what we clearly know is no alcohol in pregnancy, and so we really do need to be having conversations with our patients preconception. So as you say, with young women before they decide to fall pregnant. The other thing is the unplanned pregnancy that women don't realise until they are pregnant. So I guess it's that thing around really helping GPs to understand the importance, how easy it is to ask, how they can make it part of their general health lifestyle review that we do. We do intervene in this area all the time. The other thing is that we have our EMRs, our electronic medical records, that actually do have pop-ups and say to us, put record the person's smoking and alcohol history. And so we do have capacity to do that. So making sure that perhaps those of us who are not digital natives and not so comfortable in that space know how to use that technology to actually fill in those boxes. So once again, you've got better data, but it also reminds you to ask those questions. The other thing is really easy ways to then refer for further support. So in New South Wales, we have the Get Healthy campaigns through New South Wales Health. We also have health pathways that are being developed through our PHNs. And so having a health pathway, and so what they are as a GP is you think, oh, I've got this clinical issue. I'll open up health pathways. Oh, there's one about alcohol and pregnancy. I'll click on that and it'll tell me where I need to what I need to do and how I need to refer, what kind of supports I can put in place. So really looking at how we can further develop those pathways and making it quick and easy. And I think it's part of training. It's training from a very early age for us as doctors when we're coming in our medical degrees. But then once we get into our postgraduate training, whether it be specialist or general practice training, that having that as being core to what we do. One of the big issues for us in general practice is we're ideally placed to do everything. And we have short consultations. There are financial limitations really through the way our system works. So anything that can be done to make this quick and easy for us as GPs, but also that continuing to flag that it's an important thing and it's core to what we do is going to be helpful.
Yeah, thanks very much. So we really do need to change those systems. And you raised the interesting issue about medical education. The Foundation for Alcohol Research and Education, as many of you know, have just launched yesterday their awareness campaign funded by the federal government on alcohol use in pregnancy and its potential harms. And that's got several target groups, including health professionals, women and women at high risk. And of course the general public. So for the first time, you should start seeing soon on your screens advertisements, really getting that message across that every moment matters. So thank you, Hester. I think we'll move on now to Kirsten Black. And just to introduce Kirsten, she's a professor of sexual and reproductive health at the University of Sydney, and she's a clinical academic gynaecologist practicing in the field of contraception, abortion care, preconception care, and menopause. She's a fellow of the Royal Australian and New Zealand College of Obstetricians and Gynaecologists, I think it's called, and the Faculty of Sexual and Reproductive Health in the UK. She holds a PhD from the London School of Hygiene and Tropical Medicine at London University. So welcome, Kirsten. So Hester mentioned this issue of unplanned pregnancy. I think it's come up a couple of times already. What is the current rate in Australia? How many women these days actually plan their pregnancy?
Yeah, so it's estimated probably only about half of pregnancies are planned, and certainly our research in antenatal clinics. So and about half of those will end in abortion, and then half will continue. And certainly that's the case that we found in our antenatal population studies, where a third of women actually had not planned the pregnancy. And many of them continued for different reasons, but there was, lack of folic acid uptake, lack of optimizing their health, particularly, for a range of issues, clinical issues, alcohol, drug use, but also diabetes and overweight and obesity need ideally to really be optimized before conception.
So you run a preconception clinic, but even going back before that, how can we get young women who are drinking alcohol and not planning to get pregnant to not get pregnant? I mean, can you tell us a bit about the advances in contraception? Because I think people often don't understand that there is safe and effective and long-term contraception available now.
Yeah, but certainly we might just take a step back though, because I think that just building on what Hester said, that there are some tools that the general practitioner can use to really initiate the discussion about pregnancy potential. And there's one that's very famous, which is called One Key Question. Unfortunately, they've actually copyrighted it, but we did do some research around that. And that is really just asking women who come into general practice settings for whatever reason, sore toe, sore throat, you actually just opportunistically ask them whether they would like to become pregnant in the next year. And then depending on their response, yes, okay, either way, unsure, maybe no, then you might do a medication review, talk to them about folic acid, and then the issues of drug and alcohol use. If they don't want to become pregnant, then there's the discussion about contraception use. And really, if it's really important to prevent pregnancy, there's a whole range of, really fantastic non-user dependent methods that have also some non-contraceptive benefits. And they're the hormonal IUDs, the implant, or the non-hormonal copper IUD. So these are tools that are potentially, really helpful in any sort of setting, actually, general practice, but also specialist setting. And particularly for this woman that we're discussing, her issue of being in a situation of domestic violence actually puts her at a much higher risk of unplanned pregnancy, as well as adverse outcomes should she become pregnant. So it would be really important to talk to her in particular about those non-user dependent methods and what benefit they might have for her. In Australia, so the study that we did a study using One Key Question in Australian general practice settings, and it was actually found to be really acceptable, by the women. They really felt that it was fine for the GP to raise this issue of, their pregnancy plans with them, even though it wasn't directly relevant to the consultation. The general practitioners were mostly comfortable with it. They thought it was fine. It did add about 3 minutes to the consultation on average. So I think that, obviously we talked a little bit about the way that our Medicare GP is structured, so that it doesn't really reward so much preventative health. But I think that trying to integrate these sort of tools can be really helpful and can really just spark a conversation. In Australia, the Your Fertility website has developed one called Planting the Seed, which asks patients about their pregnancy plans. And that's certainly, and there's an online tool that we're helping to kind of optimize for women to be directed to, or to find themselves, and women and their partners, and to look at, what might be some of the issues in their health that they could optimize before they try and get pregnant.
Yeah, look, that sounds like a very useful question, and it reminds me of a study we did of alcohol use in pregnancy. And by adding a question about special occasion drinking, like weddings, and we found that it increased by 20% the number of women who had high-level alcohol use during early pregnancy. So, Kirsten, what do you think are the elements of a healthy pregnancy? There's obviously drugs and alcohol we've touched on. You've mentioned folate.
There's a whole range of issues that need to be addressed preconceptionally for the ideal pregnancy. So obviously in our society, increasingly women are entering pregnancy with high body mass index, high weight. And that's not ideal because it has the intergenerational effects, as well as the effects of adverse outcomes in pregnancy, like gestational diabetes. Many women also may be taking medication that has some implications for the pregnancy, and that might be women who are on epilepsy medication, for example, or high blood pressure medication. So optimizing weight, optimizing diabetes control, optimizing medication, and addressing drug and alcohol issues prior to conception. And the Lancet have this fantastic diagram which shows kind of what you really need to do for a healthy pregnancy and the timeframes that you need to instigate those changes. And so for weight, sometimes that may be a year, a year-long run in to optimize your weight before pregnancy, and things like stopping alcohol and smoking ideally 3 months before. And as you said, you know, the predictors of drinking in pregnancy are really, you know, women who are drinking to binge levels preconception are those that are most at risk of drinking in pregnancy. So they're all the things. The College of General Practitioners has a red book, which is preventative strategies, strategies for prevention, and one chapter is on preconception care. And there's a nice list of issues that need to be kind of ideally discussed and woman supported and a partner supported to make some changes before conception.
That's great. Could you put just a link to the name of that resource and also the Lancet article with the good figure in it up on the chat? So now you mentioned alcohol, and we know from the animal studies that even around that time of conception, very, very early on, alcohol through epigenetic mechanisms might confer some risk for later adverse health outcomes. So how do you address alcohol specifically when you see a woman in a preconception clinic?
I mean, I think it's taking a detailed history and then providing, you know, some information about some clinical advice about the issues of alcohol in pregnancy, and counselling, you know, counselling about these are the risks that we know exist with alcohol use in pregnancy, and really, I guess, discussion, motivational interview discussion about, you know, the willingness to change and to make those changes prior to pregnancy, and hopefully setting up some strategies and goals to achieve that, and some support, you know, putting in some support network.
Great, thank you. Now, my next question was going to be, do we underestimate the role of contraception in preventing alcohol harms in pregnancy? I think you've addressed that, and it does remind me that I heard you speak at a university seminar when you said to the girls, there's new contraception available and it'll last you an arts degree. So I think that's what you were referring to earlier with the longer term depot contraception. And I think it is really a key element for young women who, if they are going to drink regularly and want to prevent those harms.
Yeah, no, and absolutely. And the thing about user dependent methods like condoms and the pill, they're very vulnerable to women not taking them reliably. So women who binge drink may forget to use the condom or forget to use the oral contraceptive pill, and their fertility, you know, your fertility is really high in your adolescence and early 20s. And so they're the women that would most benefit from these non-user dependent, long-acting but reversible and very safe contraceptive methods.
Great, thank you, Kirsten. And I think we might move on to Kelly now. Now, Kelly is a clinical associate lecturer and a PhD candidate at the University of Sydney, and she's doing her PhD on substance use in pregnancy. So it's great to have you with us, Kelly. Kelly is a trainee obstetrician gynaecologist. She works in medical education at John Hunter Hospital, and she provides clinical care as a registrar in obstetrics and gynaecologist at St George and at Gosford Hospitals. You sound very busy, Kelly.
Yes, and I also have an 11-week-old child to add to the mix. But
well, just to add, that's what women are capable of doing, isn't it? Multitasking. So, clinician, educator, PhD student, mother. We're really interested.
Very supportive PhD supervisor.
That we just heard from. So, Kelly, just tell us a little bit about your PhD. What are you actually studying?
So, the focus on my PhD is really preventing unplanned pregnancies in women who use alcohol and other drugs. It's not to suggest that we don't support women who are planning a pregnancy, but for those women who don't wish to be pregnant, to ensure that they have access to, as Professor Black was saying, all types of contraception, but also education, that the people looking after them have access to providing the relevant training. And so we look at women who are both pregnant already and whether they wish to be pregnant and what their alcohol and drug use was and what they would like in the future to prevent unplanned pregnancies. And we also look at women who are known to alcohol and other drug services and to give them options to have rapid access pathways and facilitated care.
So can you tell us a bit about those rapid access pathways, because they're really important for clinicians to know about?
Yes, so we've put a rapid access pathway into 2 drug and alcohol services, one in southeast Sydney and one on the Central Coast. And what it is that we've identified some drug and alcohol clinicians who work at those sites who are willing to provide contraception services. I see the women first and ask their consent to participate in the study. They watch an educational video on all of the different contraception options. So everything that's available. They're then given the option, if they'd like, to have a one-on-one conversation with the drug and alcohol staff who have been upskilled to provide contraception care. They have the option, if they would like, of being provided most things, pills, implants that go into the arm, injections on site. And then we've developed links with the community. It's a little bit different in both sites, depending on service capability, to provide very quick appointments, usually within 2 to 4 weeks, for women who want intrauterine devices or women who have complex needs. For example, they might be on epilepsy medication, to a clinician who has got particular expertise in contraception services. All of the contraception is paid for 12 months. And then we contact the women in a year's time to see how they found it, if they continued it, if they had a pregnancy.
Great. Well, look, that sounds really interesting, and we look forward to hearing the results of that. Now, you're a young trainee obstetrician, and what we found is that, you know, anecdotally, but often there seems to be an objection by obstetricians to give women strong advice about alcohol use in pregnancy. There does seem to be a degree of skepticism about whether a little bit of alcohol won't do any harm. Have you come across this, and why do you think that some obstetricians don't routinely ask about alcohol use in pregnancy?
Look, I think many of the reasons are quite similar to what Hester said in general practice, but I was also quite interested in Angelene's experience, because I think she's touched on many of the points here. There's really a variety of factors. I think there is an assumption often that the woman has already been asked the question, either by our midwifery colleagues or our general practice colleagues, and this may or may not be correct. And having heard from Hester that general practitioners are hesitant to ask too, highlights the fact it may not be correct, and the question does need to be asked by anybody caring for a woman in pregnancy. Moving on from that though, I think there is a fairly incorrect assumption that particular patient populations are not at risk. And what I'm alluding to here is a belief by practitioners that women in higher socioeconomic settings, particular cultural backgrounds, more higher educated women are not going to be drinking in pregnancy. And the data does not support that as a finding, in fact, quite the opposite. But I think that is definitely something that when I go to various different settings and talk in obstetric services, people are surprised when I say, you know, look at the data here on high socioeconomic populations. I think in keeping with that there's an assumption that a lot of women already know the guidelines and that they would have stopped drinking before they found out they were pregnant, because they should know that, and they would have stopped more early in pregnancy without really understanding the reasons why a woman may or may not drink and what other factors might be coming into it. There's also problems, I think, in terms of seeing something as their role and being comfortable asking a question. signposting is a tool that clinicians could use to be more comfortable to ask a question if a woman is drinking, but often feeling like it's outside their area of expertise and maybe somebody else should be asking the question.
Yeah.
To ask the question.
Angelene's just made a comment, having the access to the local AA office would also be helpful. And I think she found that helpful. Just coming back to your project, you're trying to identify women who use drugs and alcohol and prevent them from unplanned pregnancy, which might be exposed. But in the meantime, presumably you're educating them about the harms of alcohol for the time when they decide they want to become pregnant. So how do you go about managing their alcohol use during that time in anticipation that they may want to have a baby later?
Yes, look, I think there's a few things to mention here. One is that you cannot really manage a woman's alcohol use if you do not know she's using it. So as we were talking about previously, really any woman who is of reproductive age needs to be asked that question, whether she's pregnant, planning a pregnancy, has unmet contraception needs. And that really includes obstetrician gynecologists see women in all settings, including fertility services. And I really was interested that Angelene had been to fertility services, and I'm filling the gaps in, but potentially had not had this discussed. And I think that's quite a common thing. Really, we need to educate women that avoiding alcohol whilst trying to conceive or during pregnancy is best, and we need to involve our multidisciplinary team. So identifying the alcohol use, recommending complete cessation, and referring and supporting women to see our colleagues in drug and alcohol, but also identifying any particular social or psychosocial issues. The other thing I'd like to bring up is what we need to have a conversation with women is if they are prepared for those referrals. It's not simply okay for us as obstetricians to say this woman needs to go to drug and alcohol and have detox. We need to have a conversation with her that she's prepared to do that. And if she's not prepared to do that, we need to have another conversation again about the risks to the pregnancy and what alternatives she might take, which might be delaying pregnancy plans for the moment and using contraception. And this is not recommended, but she's really not prepared to engage in services, what she's going to do to identify an early pregnancy. There are women in fertility services, particularly, that spend many, many years trying to conceive. And whilst we would recommend that they avoid alcohol, if they're not going to, they actually still need to be provided care and need to be comfortable to keep coming and seeing me in that period. So maintaining those links. In terms of what's available, the screening tools available that we can use, and in New South Wales, where I work, we use the Audit C tool, but the accuracy of this is fairly unclear. My own unpublished research indicates about 5% of women who have used that tool are reporting alcohol use in pregnancy, and that's similar to what other states are reporting to Australian Institute of Health and Welfare, but it's very much below what some of the cohort studies are reporting at 60%. So the questions and maybe the way we are asking them in these screening tools are not actually likely to be bringing up accurate information, and perhaps we actually just need to look women at the eye and have a conversation with them about how much they drink. And I love the way Angelene put it, not are you drinking, but how much are you drinking? What are you doing at the wedding last week? And getting the information that way.
Yeah, I think wonder, Kelly, if there's a difference between practice and research too, because in some of those cohort studies, you know, we've spent a lot of time, several hours with a woman, getting to know them at the first visit, at the second, you know, at the middle visit and towards the end. So, you know, that trust does develop, and often they disclose at the third occasion. So I think that's also an important point for clinicians. Just, you know, we can't necessarily expect that people will be disclosing immediately until they feel that there's a trusting relationship developed.
Especially not when the amount of stigma that's involved in alcohol use in pregnancy.
Right. So Kelly, what advice would you give Susan?
The first thing I'd say is to be a quite long consultation. This is not a standard 15-minute consultation. And I'd actually leave the alcohol aside in the beginning, because there is a myriad of other issues that we need to talk about first. Susan's clearly very vulnerable. She's just left a violent relationship. It's unclear to me if there was sexual coercion or even sexual violence in this relationship. It's also unclear to me if this pregnancy is planned and wanted. If Susan has safe housing, she's identified that she's single, she's unemployed. So there's many issues to talk about. I'd also like to talk to about if she's prepared to stop drinking and would like referral onto other services. Now, this is a topic to raise sensitively, but as Susan probably is early in her pregnancy, ultimately, I do want to know if Susan wants to continue with the pregnancy. If she does, I will support her in absolutely every way. But if she doesn't, at least in New South Wales, the legislation would support her in not continuing. And we should have that discussion with Susan in its most sensitive way as we can. After we've done all of that, I would talk to her about, or offer her, and she has asked about the alcohol risk to her child or her baby, and I would point out to her that her alcohol consumption to date has been high risk, because it is more than 5 or 6 standard drinks a day, and particularly that she's had binge drinking, although it's been on an almost daily basis. That places her in the highest risk category. So she has a high chance of having a baby that's affected by fetal alcohol spectrum disorder. The incidence is variable, and it depends on other things, including social factors, education, other drug use, and I cannot tell her for certain what's in store for her child, but an incidence of maybe 1 in 10, perhaps higher for her with the high risk. I would offer as part of that counselling that she could talk to somebody like Angelene or an organisation that could provide her information of what it's like to raise a child with fetal alcohol spectrum disorder.
And the National Organisation for FASD has a very good helpline and peer support and information service as well, Kelly.
That's the sort of thing that women need to be able to make their decisions. And to know what's in store. I'd also point out to her that whilst there are some physical birth defects, particularly facial defects, much of the long-term issues are not things that we can diagnose antenatally. So babies may have low intelligence, hyperactive behaviour, memory and speech impairments, problems as a baby with sleep or suckling, and will need long-term paediatric follow-up. But there are also some issues for pregnancy, increased rate of miscarriage, intrauterine growth restriction and stillbirth. And she would need to be followed up and cared for very closely with multidisciplinary care in pregnancy that addresses her psychosocial needs, as well as her physical health. She probably needs thiamine today and multivitamins. She needs encouragement to cease and recommendation if she was willing to go to detox services and rehab services. She may need parenting support, and I would do the regular antenatal care, but add in some extra things such as iron studies, liver function tests, but also regular scans looking first for structural anomalies, but also that fetal growth restriction as we go through the pregnancy. And I would then arrange her care during delivery is rather similar to anybody else, but she probably needs some extra support people given all her psychosocial needs. And long-term follow-up, both with a GP, so come and meet someone like Hester, and we talk to her about her ongoing health needs as well. Does she need things like cervical screening? Does she need contraception? How does she prevent another pregnancy with these risk factors?
Thanks, Kelly. That's very comprehensive. And I'll come back to some of the points you've raised in the discussion. And there are some questions which, again, we'll come back to. Sophie has typed in that no FASD Australia and given the website nofasd.org.au as a confidential helpline which operates 7 days per week. And she's provided the telephone number there in the chat as well. So thanks, Kelly. And I might now move on to Paul. So Paul, welcome. Paul Haber is a specialist in addiction medicine and in gastroenterology and hepatology. He's the clinical director of the Drug Health Service for the Sydney Local Health District, and he's a consultant at Royal Prince Alfred Hospital. He's a Foundation Fellow and past President of the Royal Australasian College of Physicians Chapter of Addiction Medicine. He's a conjoint professor at the University of Sydney, and his research focus is health problems and particularly liver disease related to substance use. So welcome, Paul.
Thank you.
Now, my first question to you, we've heard a bit about, managing alcohol use in pregnancy. Now, you deal at the sort of hard end of women who have problems with drug dependency and alcohol dependency. When should a pregnant woman be referred for referral to a specialist alcohol service like yours?
Thank you. I think it was very interesting that Angelene said that the obstetrician just told her to stop. And I think we have to understand that substance use disorder is a disorder. It's not something you can stop. And it's like saying to an equivalent lady, look, your blood sugar is 26, you should get it down. Just fix your blood sugar, and that would be very good for your baby and of course for yourself. I mentioned that as an example because no one would be dumb enough to suggest that. So we actually, as a health culture, do not conceptualize alcohol use as a disorder that is something that people require support and assistance that can have a treatment, whether it's psychosocial, residential, or medications. And those treatments are not perfect. They don't work 100% in every case, but they do work substantially in many cases. And it's fair to say that there are very few treatments that work 100% in any other area of medicine. So I think we're kind of in the same boat as many other areas. So when should a lady such as the case study we're talking about be referred? I think obviously earlier is better. I think if the problems are assessed immediately and are very serious and very immediate, then the referral should be immediate, that is on that day. And our usual practice would be to recommend hospital admission to an appropriate place, which has the capacity to manage safely a patient like this, both in obstetric terms, mental health, and in their substance use terms. So that, in plain language, means one of the drugs in pregnancy units where available.
That was going to be my next question. When would you admit to hospital? And you've answered that. So how would you manage withdrawal in a pregnant woman?
Carefully is the short answer.
What are the risks, Paul?
So I would like to also highlight that there's Australian national guidelines on treatment of alcohol use disorders, which a large team was involved with and I chaired. And that has actually only posted its recommendations in the last couple of months. So it's new. And there is a chapter on pregnancy, as of course there should be. And in there, we go through the answers to these sorts of questions. And
that was published in the MJA, wasn't it?
A summary was published in the MJA. So that's right. And the other place it's published is it's alcoholtreatmentguidelines.com.au. So it's available. It's a free download. Anyone can look at it. Alcoholtreatmentguidelines.com.au if you want the alcohol treatment guidelines. It's hopefully that simple. And we identify that the risks of alcohol withdrawal in pregnancy are risks to the mother and risks to the infant, and particularly if the withdrawal is severe, because that can be complicated by delirium and seizures, which would obviously have a substantial risk of a catastrophic outcome for the pregnancy, and a significant risk to the mother, of course. So we would assess early and treat assertively the withdrawal, and that means using diazepam, and that's a drug that we have concerns about in terms of safety in pregnancy, but it does seem that there's very little evidence of harm from a few days of alcohol, of diazepam treatment in sort of mid-pregnancy. And certainly this is an area for which our evidence base is sadly very slender, very little studied, basically no randomized studies. So we adopt a kind of a clinical risk trade-off perspective, as we do, you know, in many conditions, and in many conditions in pregnancy that require medications that we have reservations about using. We have to think about the risks of using it versus the risks of not using it. And so we would, and of course, we have to think about more than just Valium, thiamine. Of course, folate is incredibly important, because folate is both a critical issue in pregnancy, but it is commonly deficient in people with alcohol use disorders, as well as a range of other electrolyte problems. And folate, I think most of this has already been touched on throughout this afternoon. And admission to hospital is an opportunity to stabilise the mother, but it's also an opportunity, and it may be our only opportunity, to comprehensively identify the broad perspective of her immediate challenges, whether they are other substances, her medical situation, the status of her pregnancy, and most importantly, her psychosocial context, which is almost certainly parlous. And for this reason, we have these drugs in pregnancy services, or SUPs as they are increasingly called in New South Wales. And we have to link the lady into the SUP service. And in my SUP service in my hospital, which is a big fat hospital that has a lot of patients, SUPs has very few cases with alcohol use disorder referred to it. It'd be sort of 5%, just a few cases a year. So we are, you could be almost certain that we are missing probably many, or maybe even most cases that we could be able to assist. And I think that the kind of awareness strategy that FARE is doing, and that you are literally with today's session are doing, hopefully will go some way towards both increasing the profile, increasing our screening and detection, but increasing people's recognition that there is a pathway of support that is available if the patient is linked into it.
Yeah, thanks, Paul. I mean, I think you're highlighting for us that many women who could get some assistance to modify their alcohol intake, or indeed withdraw, are just not being referred to the right services at the right time. So, Paul, these specialised services like you propose, there's the substance use in pregnancy and parenting service you mentioned, which has sites across New South Wales. What about nationally? Is there a list of these resources available somewhere that clinicians can access, or that we could put on the FASD Hub?
I wish I knew the answer to that more clearly, but I know that there are drugs and alcohol phone support services throughout in every state, and that each of those will be able to make appropriate referrals. But they are largely restricted to the major centres, and this is a big problem, because alcohol use is actually much higher in regional parts of Australia than in the big centres. So I can pretty well guarantee you that the services are not available in the places where they are most needed.
Yeah, that's a real problem. I think you may have been involved with me in a study that Lucy Burns did some years ago where we looked at all pregnancies in New South Wales.
Yeah.
And we found that there were a significant proportion of women who had not been identified as even using alcohol, who turned up until they turned up intoxicated at the delivery. And of course, rural and remote places were women from those areas were most likely to have an unrecognised alcohol problem.
And in your particular, in that same study, you had a significant number of women who were admitted to hospital because of an alcohol problem and who were still not linked into an appropriate comprehensive system of care, which was all the more tragic. And I have to say, since that time, New South Wales has changed a bit, but I don't think the rest of the country has changed with it.
Yeah, well, look, maybe that's something that we at the Hub can come back to you for and perhaps get a bit more information, because I think it's absolutely crucial area. So thank you for that. And I might move on now to Julie Oy. And Julie, welcome. Julie,
thank you. Let me unmute and unmask myself.
Julie is an expert in, she's a neonatologist. Just got to find your bio, sorry.
That's okay.
So I don't make it up. She's a senior neonatologist at the Royal Hospital for Women, and she's a conjoint professor of paediatrics at the University of New South Wales. She's the lead clinician at the Chemical Use in Pregnancy Service, which is similar to what you've just heard from Paul, the Substance Use in Pregnancy Service in southeastern Sydney, and she's a visiting medical officer in addiction services in the Murrumbidgee local health district. So Julie, you're a practicing neonatologist and you're also an expert in neonatal abstinence syndrome. Could you tell the audience what NAS is, NAS, neonatal abstinence syndrome, and how that might harm the baby?
Thanks, Liz, and thanks for inviting me. This is really interesting. Look, I started off as a fellow many years ago, and at that time, babies were increasingly born to heroin-using mothers. We had a heroin drought in Australia in the late 90s, and that was followed by a really rapid drop in heroin price. And we got all these babies who were withdrawing from heroin. And it was a very, I guess, a newish phenomenon in Sydney at that time. And these little babies were in our hospital for ages and ages, weeks to months, and we had to set up a clinic to look after these babies. And what we found over the next few decades, I guess, we've been running this clinic since 1997, first led by Dr. John Feller, who has now since retired, that our little children had increasing problems as they grew up. So neonatal abstinence syndrome stands for newborn withdrawal from maternal drugs or substances of dependency. We use the term chemicals because even though the babies were withdrawing from heroin then, we realized that the babies could be affected by all types of substances or chemicals, including alcohol. But I have to say that over the last few decades is that we've looked after more than 1,500 babies and moms, of course, who were using various drugs or substances, usually opioids or maybe sleeping pills, benzos, now increasingly the newer street drugs like GHB and ketamine. But in the last 20-something years, we've probably only ever seen less than 10 mothers who admitted that they had a problem using alcohol. So our service is in the eastern suburbs of Sydney. And if anyone knows Sydney, it's in Randwick, and it drains some of the richest areas in Australia. But, you know, you can get problems from alcohol, whether it's from beer or from Dom Perignon champagne. And it's a condition that we are not taught to look after. That's the problem with our clinicians. We are very, very hesitant to ask moms whether they use any types of substances, not only alcohol. It's not part of our upbringing. So if you look at our medical school curriculum, we're very comfortable with, we are taught to ask people whether they have pain or whether they have anything physically wrong. But things that are accepted in our community, alcohol, especially in the Australian environment, is something very, I guess we're very uncomfortable with. So that would be my main problem as a clinician working with babies.
Yeah, so when you're seeing a baby in the neonatal unit and you look in the records and there's nothing recorded about drugs or alcohol, you have an opportunity then, I guess, to go back to the mother or to go to the obstetrician or to the nurse to get that information. Is that something that you try routinely to do? Because that is very useful for the paediatrician down the track.
Exactly. And unfortunately, the answer would be no, because in many of our, I guess in the daily situation, we're consumed by a lot of other things. If you're in an NICU environment, you're trying to keep the child alive. When you are looking at, other conditions like outpatients, you're looking at the hips, you're looking at the heart, you're looking at the brain. You don't ask, you don't go back. And often we don't have the opportunity to ask the mom, because many of our babies who have parents with problematic substance use disorders are placed into foster care. And there is also a difficulty with transmitting information to the foster carers. Often when the baby's picked up by the foster carer is totally unaware. They're not allowed information of the background substance exposure. So by the time they come to see us, no one knows what on earth the baby's been exposed to.
Yeah, look, you make two good points there. One is that it's clearly a lack of continuity, isn't it? A lack of recording during pregnancy that is available to the neonatologist, then a lack of continuity between the neonatal and obstetric care and the paediatric or general practice care. Hopefully, do you think that'll improve with electronic medical records at all?
Oh gosh, we have problems using a computer, so we need our fellows' help to do that. Hopefully, there will be better linkage with using EMR. But what I think, what our experience is that we have to get over our reticence with asking. We have to be, as clinicians, we have to be supported in learning how to ask the parents about whether there was any substance exposure.
Yeah, and I think taking on board the fact that women tell us overwhelmingly that they want to be asked and given clear advice. What we've done in Newcastle, and I think this may subsequently be rolled out across New South Wales, is embedded the questions about alcohol in the electronic medical records and provided information about how to advise and where to refer should there be a problem. So I think that's one way of doing it, but that's of course not mandated. So, you can choose to omit those questions, but at least they're there and we're finding that clinicians are asking the questions. So, Julie, when we talk about neonatal abstinence syndrome, and it's usually a withdrawal from drugs, but how does alcohol contribute to the problems you see in the babies in the neonatal unit?
So like many of the other panelists have suggested before, is that often when we have a mother who's using substances that can cause neonatal withdrawal, the issue of alcohol is often clouded. It's often put right way at the bottom of the list of priorities with cigarettes and even increasingly with cannabis. So sometimes the mom is using a lot more that we're concerned about, like heroin, methamphetamines, other things like that. And we often neglect to factor in alcohol and the legal substances into the equation for the baby. So what we have is a biphasic issue. So we've got the neonatal withdrawal, which we have to treat right away. Otherwise, more than 80% of these babies could actually die. And then when they recover from it, they go home, they look healthy, they look great. And then they come in with the other long-term issues that we see commonly with both substance exposure as well as alcohol exposure. Things like behavioral problems, maybe cognitive issues, autism, spectrum disorders, a whole gamut of things. So I think the two conditions together can exist, but they cloud each other.
Yeah. Okay, well, look, thank you very much, Julie, for those insights at the baby end of the spectrum. So what I'd like to do now is to ask the audience to put their questions into the Q&A. And I would just like to see if there have been any questions so far. There was a question from Cheryl, and it related to whether a clinician seeing a patient can find out whether previous clinicians have asked the questions about alcohol. And I think, Cheryl, really you've got to do that via the patient. And often they will remember or know whether those questions have been asked. And I guess the issue of electronic records comes in here too. If people have agreed to have their information in electronic records, then potentially one doctor will be able to check the records from prior consultations. Okay, so we're now ready to do the Q&A, and perhaps all the panelists could turn their cameras on now. And there's a question here to you, Paul, from Cheryl. Paul, are the services that you mentioned available in other states? And I think you might have partly answered that question. Want to just address that again?
Yes. So I also typed something. Sorry, I had to start my video 3 times. I just did a quick PubMed search, not PubMed, Google search while we were waiting for this. And there's a well-organised and publicised service at St Vincent's in Melbourne, led by Yvonne Bonamo. So there are well-structured services here and there, but and Kate can correct me if I've skipped anything, but I think we have to go via general drug and alcohol services in the major hospitals to come as close as we can to what is operating in New South Wales. In New South Wales, what is new since 2017 is funding for services outside the teaching hospitals. And even there, they don't cover the whole state. But there is, Julie, for example, I know is working with the Murrumbidgee people, LHD, very nicely, and that's lovely to see. But that's more of an example what should happen everywhere rather than saying it is happening everywhere.
Can I just add, Paul, that as you mentioned earlier, there's a national number, ADIS, the Alcohol and Drug Information Service, and you can find out what services are there in your state, and that's for the public. Then for health professionals, every state or territory has a specialist advisory service. So if you're a GP or a midwife in the middle of nowhere and you haven't got a local drug and alcohol team, you can ring and get advice from a drug and alcohol specialist nurse or a drug and alcohol specialist doctor for how your local team can manage, help support that woman through her pregnancy and manage the withdrawal, etc.
But absolutely, but I guess the flip side is to say, first you find there's a problem, then you find the solution. And you won't solve these problems by having a phone number at the back of your calendar or something. You find these problems by finding these problems, and then you work with solutions. And that is in fact our huge challenge.
Can I just add one thing to what Paul said, is there's also a huge lack of services that take women with babies and women in rehabs. And in Sydney, we're pretty lucky, we have 2 or 3, but in rural areas, I think there's very little, and I don't know what the situation is in other states.
Yeah, I think that that is a key issue, and I think that having spoken with some of the NGO services, it's not that they don't like women, it's rather that the skills and the range of health professional expertise that you need to do this challenging area of practice safely and effectively lies beyond what many community drug and alcohol rehabs offer. Many of them don't have a doctor, many of them don't have a nurse, and they have a purely psychosocial model. And it's probably correct that we should not admit a vulnerable woman in this challenging situation to a place like that, but rather they should go to a proper hospital where the full range of services are available. Unfortunately, even in the big hospitals, I mean, I work in a big hospital, and to get a hospital bed for any patient is very challenging, and to allow that patient to stay in that hospital bed long enough to deal with these complicated issues can be an additional problem. So as soon as that lady can walk up and down the corridor and looks okay, there can be a bit of a pressure to get her out for the next patient. So I'm not sugarcoating it by saying that the big hospitals can solve these problems easily either.
I'm just noticing in the questions, there's a couple of questions there for Kelly. Kelly, can you see those questions? The first one was, is there a way to connect professionals the woman is consulting with so they can know if the question regarding alcohol use has been asked?
There's not a great way, and I think Professor Haber has highlighted that in New South Wales we have some substance use and pregnancy networks within the local health districts, and there is communication throughout those. But there isn't a great communication with primary care. Hester and I, unfortunately, are not communicating well on this issue, and there's not necessarily great communications to our neonatology colleagues. So Julie and I also are not communicating well on this issue. The substance use and pregnancy teams do bring it together a little bit, but again, if alcohol isn't identified as an issue, then there's no communication along the way anyway.
I mean, we do have potential through My Health Record. You know, it's not doing a great job, but the other thing is, you know, once again, thinking about EMR and you know, just if we're seeing someone to put that information into the discharge summary, to put it into the patient's notes so it's seen within the LHD, but also that information is sent out to primary care. Kelly, there was another question for you, which was, would you recommend specialist care for a woman who's had an alcohol exposed pregnancy?
What I would recommend and what I would like to see is that alcohol exposed pregnancies are treated like any other condition that causes both risk to higher risk to the mother and baby, and are treated in a multidisciplinary team with an obstetric involvement. So largely, at least in New South Wales, they are treated in a multidisciplinary team, and there'll be a midwifery-led model of care with referrals to drug and alcohol. And certainly when I worked with Julie at Randwick, referrals to her for follow-up. But obstetric services, obstetricians are often not in that loop, and I'm not aware of too many. That there are some obstetricians at Royal Prince Alfred, but too many services where there are regular obstetric care. And I think probably there should be. These conversations, as I discussed earlier, are difficult and involve the teratogenic risks, the long-term health risks, the options available for termination, and really do require at least some visits and discussions with a specialist. So that's what I would like to see, but that's not really what we have as our system at the moment.
Now, we have lost our chair. Liz has disappeared off into the ether. I don't know quite what happened there. She sends her apologies. I think we're at finish time. You know, so look, I'll just take the role and say thank you to all of our fabulous panelists. Angelene, particularly to you, thank you, thank you, thank you. It's so great to have you involved in this as a biological mother. It's really important, and I've been watching you tweet away there on Twitter and standing up and being heard and being seen and sending those messages out. It's really brilliant. And to all of that wonderful health professionals, I know it's something we could keep talking about for hours, but it is time to finish up. But thank you, Kelly, Julie, Kirsten, Kate, Paul, and myself. And there's a couple of other people down the bottom there, Kate Harford and the FASD people who are in the background there. Thank you to everybody today, and thank you to everybody that attended. We'll finish there.
Thank you.
Thank you.
Bye all.